So last but certainly not least, client factors and how those contribute to psychotherapy outcomes. In fact, I'm very tempted to say last and most. Reviews of the research suggest that between 30 to 40% of the outcomes of psychotherapy can be attributed to client factors. And that's absolutely huge. And as clinicians, of course, you're all nodding, you're thinking, well, yeah, of course. The client really is the biggest factor in therapy. So there's an awful lot of research on client factors. So I'll echo what's already been said. It's really impossible to do a thorough overview of that. So I'll just focus on some highlights, the things that I find particularly interesting. And most of this will be concerning adult clients. So one of the first things, of course, you think about as a clinician is the severity of the problems of the person sitting in front of you. And it makes a lot of sense that the more severe those problems are, the more difficult it is going to be to have a good outcome. And you can think about severity in a number of different ways. Functional impairment, so the impact that that problem actually has on their ability to function in their lives. The severity, how severe those symptoms are, and how long they've had the problem. All of those things contribute to poorer outcomes in psychotherapy. Subjective distress is a little different. Moderate to high levels of internal suffering and distress about the problem actually predict better outcomes. So you can imagine that if somebody isn't particularly bothered by a problem that they have, then they're going to be less motivated maybe to engage in that hard work of therapy. So having a little bit more distress can actually be helpful. And of course, comorbid personality disorder, history of sexual abuse, those things are associated with poor outcome and also with dropping out of therapy. And in particular, borderline personality disorder, and to some lesser extent, obsessive compulsive personality disorder. Psychotherapy expectations. So the old-fashioned word for this is hope. Does a client expect that therapy is going to help? That has a huge impact. Is therapy going to make me feel better? Is it going to make my life better? Of course, that has a huge impact. Positive expectations for treatment outcome are related to staying in therapy longer and having better outcomes. And expectations regarding outcomes is one type of expectancy, but patients have all kinds of other expectations about therapy. What it's going to look like, what the sessions are going to involve, what the therapist is going to do, what the patient's expected to do. So those are more treatment-related expectations. And you can imagine that if somebody arrives and expects to talk primarily about their childhood or primarily to get advice from you, and those things are not borne out, that could actually lead to dropout and poorer outcomes. And that's actually true as well. So when expectancies about treatment aren't met, that can interfere with staying in therapy. Readiness for change. So this is based on Prochaska and DiClementi's trans-theoretical model, which I'm sure you've all heard about. The idea that behavioral change can be broken down into stages, where people are at different points of readiness to change problematic behaviors. So pre-contemplation, I don't have a problem. There's nothing wrong with drinking coffee. Contemplation, well, yeah, maybe I should cut down, but I'm not ready quite yet. Preparation, maybe next week. I think next week I'll cut it down to one a day. Action, that's where you have concrete change behavior taking place. And then maintenance, there's a long-term sustainment of change behavior. So as you would expect, where people are at in terms of their readiness to change really has a big impact in terms of how they do in therapy. So patients who are in the preparation stage have better treatment adherence and outcomes than those in pre-contemplation or contemplation. And it seems that if you can progress from one stage of therapy to the next early in treatment, that really improves your outcomes. And there was one study where if you can move from one stage of change to the next in the first month of treatment, I think you double your chances of taking action within the 6 months of beginning therapy. So I mean, that's an amazing effect. And there's some research about the idea of matching interventions to stage of change. So you can imagine if your pre-contemplation coffee drinker is, not even really thinking about making a change, and you charge in with a behavioral plan for cutting down, you're going to meet with, I think, what we used to think of as resistance. But hopefully we could maybe reframe as you're not really matching your intervention to the stage of change of the patient. So you're not where the patient is at. So there's research looking at whether matching interventions to stage of change leads to better outcomes. And there's some research on that at this point. Attachment style. So, George, you'll have to correct me if I butcher this definition. So this comes out of Bowlby's work and Mary Ainsworth's work with the strange situation. And, in a nutshell, the idea is that our internal working models of ourselves and our relationships with other people is formed in our early caregiver relationships, and that we carry that forward into our adult lives, and it affects how we see ourselves and also how we see others in relationships. So you can imagine that that's going to have a huge impact on a psychotherapy relationship and thereby the outcome. So roughly, attachment styles can be divided into two types, secure or insecure. So a secure attachment is essentially a positive internal working model of yourself, other people, and relationships. And insecure, either an avoidant and sort of dismissing attitude towards relationships, or an anxious, preoccupied, negative model of the self, but positive model of relationships. So that's the kind of the preoccupied or clingy kind of style. So in fact, higher attachment security is associated with better outcomes. So securely attached adults seem to have an easier time engaging in treatment, staying in treatment, and establishing real trust with their therapist. Higher attachment anxiety is also associated with worse outcomes. So although an anxious, sort of preoccupied attachment style, it can seem very interpersonally engaged, but I think those people have trouble really establishing trust and engaging in therapy. And attachment avoidance is not necessarily associated with poor outcome per se, but those are the people who may be dropping out of treatment. And it seems that it finds very hard for them to ask for help or accept help when it's offered. So coping styles, internalizing and externalizing. This is essentially the idea that when we're under stress, most of us tend to fall into one of two camps. Internalizers under stress will withdraw, think about their internal experience, tend to avoid contact and stimulation, whereas externalizers will call up all their friends, do external behaviors, external ways of coping, and it seems that there's roughly two styles of coping. Neither one is associated necessarily with better or worse outcomes, but it does seem to be that there's some advantage to matching an intervention to that style of coping. So internalizers do tend to have better outcomes with insight-oriented or awareness-oriented therapies, although there still does seem to be some benefit in initially focusing on symptoms. Whereas externalizers have better outcomes with symptom and skill-oriented therapies. So I guess I just have some final thoughts about all that, and some of it is based on what you've seen already. And the first is, of course, that client factors don't operate in isolation. They operate in the context of that therapeutic relationship. And the other is that, although I'm calling these client or patient characteristics, of course they're not static, they're flexible. Even things like attachment style. Research shows that can change with treatment. And then, of course, things like stage of change. You would hope that those things would be changing over treatment. So it's something that needs to be monitored and measured repeatedly. And that I think research is moving away from the idea of correlating a patient characteristic with an outcome and looking more at interactions, between things like severity, and therapeutic alliance or stage of change. So those are just some things to think about.